All right, how we doing? Yeah? Morning, we're excited? So, my name is Rowland Robinson. I'm Franco-American. My mom is French, not a US citizen. And my dad is American. I was born in Providence, Rhode Island. But I've been started living here in Maine since the age of 5. And I had the privilege of working on and off on the opioid crisis for the past 10 years. But my experience really starts before that. Had opioid use disorder, heroin, fentanyl, pills, everything you want. I too struggled with alcohol abuse, and we can talk about what's the difference between substance use, abuse, all that type of stuff. It's very cultural, right? And so I was abstinent for 2.5 years, and then now I've gotten to a point where I use casually once a month, a couple times a year, but it does not impact my life. And so I worked in the state legislature, I worked in the OBH with Kathleen Kutu and Sybil and Gordon Smith, and then I've also worked in Senator King's office on veterans issues down in Washington, D.C. And over the past 2 years, I had the privilege of visiting or living in the Netherlands, Portugal, and Brazil to understand what we can learn here in Maine and here in the United States from their experiences. Right, we're not the first country in the world to have had an opioid crisis, right? We're not the first country or the only country to experience a drug crisis, right? And so the idea is like, what can we learn from these other countries and what is transferable here to the United States, right, here to Maine. I am recording myself. I'm not sure if I'm gonna post it online yet. This is just for me to kind of have a thing, because I just finished about a month ago, so this is still kind of like figuring out the messaging and stuff. So the title is Community Values, Public Health is Public Safety, right? And why do I say community values? Because I think a lot of times we talk about family values, right? Which is usually wrapped in a lot of abstinence-based theory and a lot of morality, right? And then on the other side of that, we kind of have the, human rights approach of, not drug users can do no wrong, but, you kind of the victimization, harm reduction aspect, right? And what I want to bring this back to is kind of the community, right? Because whether you're a person who is using drugs, or you're a family member, or you're a community member, right? Drug policy impacts all of us, right? And so when we are talking, to Tessa's call to action, when we're talking with people, we have to realize that drug policy impacts all of us, impacts the community, not just the person who's using drugs. So kind of stole the thunder of my next slide, but we're gonna do it anyways. The first thing I wanna start with is and this is gonna be an interactive, I'm gonna try to make this as interactive as possible, which is, what does it mean to solve the opioid crisis? Do I see some hands? Catherine? Can you give me like one example? Yeah. Okay. How about you, Elise?
I also represent the city.
Okay.
Fewer overdose deaths.
Yep. Great one. Somebody else?
Easier access to medications.
Yep. Fantastic. What about this side?
Actively addressing stigma.
Actively addressing stigma, love that, yep.
People getting their lives back.
People getting their lives back, right? Integration, reintegration, we're gonna talk about all of those things. Who is impacted by policies directed at people who use drugs?
We all are.
Hell yeah, all right, there you go, easy crowd. Okay, third question. What even is addiction? And I want to talk to my Portuguese friend over there, right?
Yeah.
So tell me a little bit about your experience with your family, if you're open to it in Portugal.
So, I was raised in New Bedford, Mass, not far from Providence. My family's from Portugal. We had a vineyard. We made anywhere from 300 to 500 gallons of wine a year. We had wine with every meal, including breakfast. Growing up as a child, in kindergarten, I was having wine before I went to school. it's not considered drinking, it was just part of the meal. I never saw my grandparents take a drink at night for the sake of drinking. They had tea or coffee. But we had wine with every meal. And it was just the way it was. It wasn't considered an addiction, it was just life. It was food.
Thank you for that, Dave. Right, and what is my point there? Right, my point is that for Dave and his family, and I lived 7 months in Portugal, having wine at every meal is considered normal, is considered culturally normal. Here in the United States, that'd be considered problematic, right, for the average citizen. If you go to Saudi Arabia, right, they'd probably put you in prison, right? And so I think when we're talking about, kind of addiction and what is considered problematic use, I just wanted you to, kind of have that sense in mind, right? So we're going to review this at the end, but my vision is a policy centered around individual dignity, connected communities that is grounded in evidence. The goal is to curtail overall drug use, ensure safety of people who use drugs, and reclaim peace in public spaces, right? The values are compassion and pragmatism, and then the mission, less use, safe use, and no public use. Who is impacted? We already did this, and you guys did a lot of these. I do want to mention just the comorbidities part, right? When we don't have certain service programs and none of these harm reduction programs, we're putting people at risk for other health problems that can live out even after they've recovered or even after they've kind of reintegrated into society, right? And I have some friends who, because of their drug use 10 years ago, right, are still dealing with some of the healthcare impacts of that is not addiction, but related. So that's where the ensuring safety comes in. So this is just to Dave's point, 20% of Portuguese drink every day, but according to the Portuguese state, only 4% of people have alcohol dependency, 9% of people in the United States drink every day, and alcohol use disorder is considered around 10%, right? So just looking at how culture shapes our perceptions, right? And I do want to make a note here that according to the UN, 78% of people who use drugs do so recreationally, right? And so when we're talking about drug policy, yes, we are talking about people who have problematic use, but we also have to recognize that a lot of people use drugs in a recreational way that does not impact their life. We're going to be talking a little bit about stigma here, but I think it's really important that we do not stigmatize the person, right? The person deserves access to care and to dignity, but I think, and this is what I've learned across the Netherlands and Portugal, is that it is okay to stigmatize behavior, right? And we're going to talk a little bit more about that in the context of these countries. So who here has heard of the Netherlands? All right. Who here has heard of Amsterdam? All right. Who here thinks it is just a heathen of partying and lawless drug use? All right, most people, right? So, Amsterdam is to the Netherlands what New York City is to New York State, right? And the point there is that Amsterdam has this reputation, but Dutch culture is actually quite conservative, right? And so one of the things that we think about when we think about Amsterdam, we think about the Netherlands, is that we think about coffee shops, right? Which is a place where people can go and smoke weed, and they've had it for the past 70 years. But I want to give you an example of, there was one cannabis advocate who tried to get actresses and business leaders and music producers to come on camera and say that they use drugs, that they use cannabis, and none of them agreed. None of them agreed. Why is that? Because culturally, it is still seen as a negative thing to smoke cannabis, right? People who I talked with who worked in coffee shops do not tell their family that they work in coffee shops, right? Why am I saying that? Because when we talk about stigma, right, I think there's the perception that I had when I left was that we have to change the mentality of the country. We have to change how the everyday person thinks about drug use. And what I discovered is that stigma, that's very hard to change, right? I mean, thanks to Snoop Dogg and Martha Stewart and all these people, right? We were able to kind of change the culture around cannabis, but that is something that is beyond what policy can do itself, right? And so, just in terms of like Netherlands, it's a polder model, so everybody's voice is at the table, so it's a very flat society, a non-hierarchical society, tolerance policy, individual freedom, community peace, and fiscal conservatism. And I think they said it best here in the 1995 report, which is drug use itself is not a risk to society, but the use of drugs can never excuse damage or nuisance to others, right? And so I'm going to run through the Netherlands heroin crisis a little bit for those who aren't familiar with it. First overdose started in 1971, peaked in 1984. It had to do with a mix of an economic downturn, huge migration from its former colonies, and also American service members coming back from Vietnam, and instead of going to the United States, moving to the Netherlands, bringing their drugs habits with them, and also bringing the supply, right? And at the same time, you had who here is aware of the French Connection in Marseille? Anybody seen the movie? They're in the back, right? So all the drugs used to go through Marseille, right, and then to the United States. And then the French police kind of broke down on that. Where did the drugs go? They started to go to Rotterdam and then the United States, right? So you had a huge influx, right? So I just want to say that, like, when we talk about how does a drug crisis or opioid crisis come about, there's a lot of different factors that come into play, right? Medical interventions. So we love to talk about medical interventions in the policy world, right? We talked about low threshold MAT, where folks do not need to drug test in order to have MAT. We had the first syringe service program in 1984, right? And what was the cool thing about the syringe service program? It was thought up by a person who used drugs, right? And that is because of the model of making sure that everybody has a voice at the table. It was a person who was using drugs on the street and saw their fellow PWUDs, people who use drugs, leaving syringes in playgrounds. And he said, I don't think that's right. Let's create this program, right? You had the first drug consumption room in 1994. 1994. It's 10 years after the peak of the crisis. Why do we think that the drug consumption room only came 10 years after the peak of the crisis? Stigma? All right. To address public drug use. That's actually right. But we'll go with that.
Dare.
Gas use risk, right? So remember what I was telling you before about how the Dutch really love their kind of clean streets and their public safety, and you're not allowed to make noise when you're outside, that type of thing. The drug consumption rooms, what they're called there, drug consumption rooms, not overdose prevention sites, right, is because the goal was to bring people inside, right? It was to prevent public drug use primarily, right? And the overdose deaths were a lot less and less of an issue, right? And so we're going to talk about this a little bit later, right? But when you allow people to access services when they're still using drugs, you can actually come in contact with 65 to 85% of the people who use drugs. Here in Maine today, I was at a dinner last night where we talked about this. We have no idea how many people actually use opioids in the state of Maine. We have no idea what percentage of people who use opioids are accessing treatment, right? And so we have no denominator. So I think creating easy access is a way to engage those folks and get a better sense. Now, let's talk about treatment. The Netherlands is the most open when it comes to allowing people to use treatment services, right? And yet, only 60% end up using MAT, right? Be it buprenorphine or methadone, right? And so I think that so why do I make a point of that is because MAT alone is not going to save us, right? There is no silver bullet, right? And so they used heroin-assisted treatment starting in the 90s, and you have 5 to 8% who are on heroin-assisted treatment, has heavy restrictions. About 10% use the 12-step program, 20% just kind of use on their own, use their own supply. And the age of patients in these programs, MHT, HAT, goes up 10 months every year. Basically meaning that that it's constant and people stay with it throughout a lot of their lives, right? And I just want to put this out there just so that you can think about, just like, yes, medical interventions are important, but they also have a limit, right? And so that's where we kind of come into non-medical interventions, right? And so medical interventions alone won't reduce homelessness or public use and does not increase community integration or lead to safer streets, right? So all the stuff that we just talked about low threshold MAT, about heroin assisted treatment, all this stuff which is like, oh my goodness, right? Oh my goodness, they were able to do all these things, and it's a small country. It's a small country, 500 people per square mile, right? You have you don't have rural, everybody can access a doctor relatively safely. You still had public use, you still had homelessness, right? Until they allowed people who are still using drugs to access services, housing services, integrated day use, that's what drug consumption rooms come in, right? Caseworkers, all of that stuff, right? So I think that was probably the biggest lesson that I learned from the Netherlands. The other thing that I learned is that this is all great, and as public health professionals and advocates, we love to talk about the public health stuff, right? But at the end of the day, there is also a stick, right? If you provide easy access, you might get 90% of people to come into the services, but you're still going to get 10% who are, I know better, I'm too cool for school, right? And, I want to be out here on the street. I don't want to go into your centers. I don't want to do your stuff, right? And what the Dutch did is they said, well, we don't accept that, right? You have access to housing, you have access to social services. If you continue to stick on the street, we're going to put you to jail, right? And that was the stick, right? And it only worked because you had those two. Any questions before I move on to Portugal? I apologize if I'm going a bit fast. Yes, sir.
Sure, the question I had was regarding the average age of the patient going up. Does that also speak to prevention efforts to keep younger people from getting to the point of a problem they don't need these services as much?
Yeah, it's a good question. Prevention, I'd love to talk about prevention a little bit later because I think we'll get to that. I think I didn't mention this, but all of these reasons that I just already mentioned is why the crisis stopped being a crisis, right? The other thing that happened was the arrival of AIDS, right? So the arrival of AIDS came in the 1980s, and all of a sudden, the subculture around heroin use stopped being cool. It stopped being like, oh, we're fighting against the system, it's the 60s, it's the 70s, we're doing heroin, rock and roll. And it started being like, oh, people are dying, we're dying, right? And so you also had a cultural thing that made it so that folks, new folks, didn't want to use heroin anymore, right? So what we were talking about here, the 10 months a year, was MAT, HAT, folks that's more opioids, right? But does that mean that people went and did, ecstasy or cocaine or other things, right? Right now, crack cocaine is a big thing in Europe, right? So I think, did that answer your question a little bit?
Yeah, no, makes sense.
Got it. In the back.
So, in essence, like, once you were making society as using your parts, it was like you either go to jail or you
Sorry?
So say, like you were saying, once a person was labeled and they were documented as a user, or people that were, that were like a menace, that weren't doing the right thing, was the option to either get clean and take these services or go to jail?
Great question, right? And I appreciate the clarification. Not get clean, right? You can continue to use drugs and get housing. You can continue to use drugs and get workforce development. You can continue to use drugs and go to a caseworker. You can continue to use drugs and we're going to try to reconnect you with your family. What happens when, through both, this is the example in Netherlands and Portugal and Brazil, what happens when you allow people who use drugs to access these services even when they're still using drugs? Say yes, James, you're in front of me, sorry. What happens?
They use more of the services, so they get the mental health care.
Mm-hmm. What happens to their drug use?
It decreases.
Decreases.
Yeah.
It decreases, right? In Brazil, we'll get to this point, I'm jumping ahead, right? But 80% of people in Cracolândia who are part of the Braços Abertos program reduced their drug use by, I think it was over 80%, right? Right? And that was crack cocaine, right? And so that is why when I mentioned at the very beginning that the goal is less use, right? It's because actually when we provide these programs, people do use less drugs. Because why do people use drugs, right? To soothe. We were talking, I saw some art stuff there. Well, if you have a house over your head, you're reconnecting with your family, maybe you have some form of employment or a way that you can win your own money and spend your own money, right? Then you don't need the drugs as much, right? Maybe you still use a little bit, but are we more focused on people kind of being abstinent next month? Or are we okay with going through a program where they're going to be using 1/10 of what they were using 3 years from now, 5 years from now, right? And that's kind of what they're doing here. Any last questions before I move to Portugal? Yeah.
This may be a better question at the end after you talk about your case studies, but
Yeah.
I'm interested if you've seen kind of upstream social or cultural effects in the community, like loneliness or isolation or hopelessness, as we just heard in the keynote,
Yeah,
that are kind of driving some of this, and then increased invitation into treatment environments actually increases hopefulness or reduces loneliness and then becomes integrated into a treatment model.
So I'm not sure I'm following you with the treatment, but I think where I'll take that is kind of this a virtuous cycle, right? Which is about community and reducing loneliness, right? If you go to Deering Oaks Park right now, it's pretty empty. Right, and the folks who are using it are people who are not all of them are homeless. Actually, I was talking with the Preble Street folks, right? But people who are using substances in public, right, where families don't feel comfortable going there. All right, when folks who are still using drugs have access to housing, when they have access to drug consumption rooms, when they have access to day spaces, who can go into those public spaces now? Right, everybody, right? And so then we have more community connection, right? And then we can have fairs, and we can have Shakespeare in the Park, and we can have all the other arts and things in third spaces that we need, that we call community. And that's why one of my points is connected community, right? And reconnecting community. So I don't know what my time is, but I think we're going to keep going for Portugal. Portugal is completely, oh, yep, I'm back.
I do have a question. These drug consumption rooms that they have in Europe, how has that affected the overdose fatalities?
Great question. Drug consumption rooms in Europe are not viewed as overdose prevention necessarily, right? Why is that? Because they don't have fentanyl, right? And so their overdoses are a fraction of what ours are, right? So my argument, what I would argue, is that if we want to really reduce overdose deaths drastically, we have to improve the supply, right? We have to improve the supply, right? And so whether that is through, and I spent some time volunteering at the Safe Consumption site in Paris, right? And so folks that would come in there would either be using methadone or buprine sulfate, right, which is a form of morphine that doctors would allow, that regulators would kind of let doctors prescribe to folks, right, and kind of turn a blind eye to the fact that, it is what it is, right? Because, so, we can get a little bit more to that, but so it's not as much of an overdose prevention. I think Paris had 1 overdose a year, right? When I was in the Netherlands, I spoke with this group, and they're like, oh, we could never do what the Americans do. We could never be the harm reductionists in America because having to deal with overdoses every day is too stressful. Like, it's too much. I would quit. Right? That's one of the guys who was running the busiest drug consumption room in Amsterdam told me that quote. All right, and so for them, it's just like a thing to kind of get people inside, make sure they're using safely and stuff like that. But if we're talking about overdose prevention, we need to talk about supply, right? And we need to talk about increased access, low barrier treatment, that type of thing, okay? Portugal. Who's heard of Portugal? Who has heard about the decriminalization project in Portugal? Okay. Who knew that Portugal was one of the last dictatorships in Europe? A couple, right? And so we have to remember that up until the 1970s, infant mortality was quasi 40%. Illiteracy, 25%, running water less than 50%, electricity barely 60%, right? It was called the Estado Novo. It was intertwined with the Catholic Church. And so we were talking about a very hierarchical and very moralistic society, right? Now we were comparing the Netherlands, very flat society, communitarian, not very, Christian, but, kind of low key. Right? 99% of Portuguese are Catholic, right? And so I just wanted to kind of talk about those cultural differences a little bit, right? So you had the Carnation Revolution. What came before the Carnation Revolution? 13 years of Vietnam-style jungle warfare in their colonies, right? Portugal started the age of exploration and ended and had the last colony until 1999. They believed they were very special. They controlled Angola, Mozambique, Guinea-Bissau, Cabo Verde. Portugal only represented 4% of their empire landholding, right? Just to give you a sense. And they fought for that very strongly. So, you had over 1 million people in Portugal who were drafted to go and fight in these jungles. And then when they lost, in 1974, you had over 500,000 votunados, which are people who lived in the colonies, who went back to Portugal. And you went from a very strict, hard anti-communist, dictatorship to all of a sudden a social democratic, quasi-communist kind of leadership within the span of like 2 to 3 years. Imagine that. It's kind of a lot to deal with. And we're dealing with a lot here in the United States right now. Right? And now imagine you just went from a hard right dictatorship to like a quasi-communist social democracy. There's a lot of feelings going on. People are not really sure what is up, what is down, right? And so, people would use cannabis, right? But and nobody knows why, but sometime in the 1980s, cannabis was no longer available in the market and heroin appeared, and so people who were buying cannabis ended up buying, just bought heroin instead. And because of the lack of information, right, this was a very closed society, uneducated, people just didn't know what heroin was, and they started taking it. And by the 1990s, so 10 to 15 years later, you have 1% of the population using heroin, 350 deaths a year, which they considered a lot. And the largest open air drug market in Europe, 5,000 people a day. Right? Why do I say all this? Because right now we think about Portugal, I was just like, oh, let's go to Porto, let's drink some wine. Let's go to Lisbon, let's go to the museums, which we should do, it is great. But I'm just saying that it wasn't always like that, right? And when we're talking, I think these are numbers for Casal Ventoso, 80% of people had hepatitis C. Or people who are injecting drugs. 60% had HIV, 90% had no access to treatment, right? So it's very similar to what we have in the United States today. I mean, in terms of the access to treatment, very, very much what we do today. We never learned how to discuss our feelings. The revolution upended the lives of a generation without the tools to express their frustration and vulnerabilities. Heroin soothed, right? And this economic aspect is really important when we even look at Maine, right? And the gutting of our rural economies, of our mills, right? And why do I sometimes have an issue when we're talking about prevention and that type of thing, is that, for me, prevention is about teaching resilience, right? And teaching interconnectedness, because you never know, how could they have guessed that heroin was going to arrive randomly in the 80s without, with the extension of cannabis? Like, how do you manage the fact that your society just went through a transformational change from a dictatorship to the social democratic democracy. So, road to reform, basically until, in 1987, you had the first dedicated treatment in Lisbon, in an outpatient. It was immediately overwhelmed, and 16 satellite sites were created. By the way, that 1% number, if that sounds a lot to you, I think I was checking the SAMHSA website the other day, and we're at 2.2% of people in the United States with opioid use disorder, right? So we're twice as bad, right? 1997, so this is, over 15 years after the start of the crisis, government mandates evidence-based treatment practices and with multidisciplinary teams for non-state run treatment centers, right? So no more, go, and might piss off a couple people with this, but no like month-long go pet a horse and like have a good time, and like, it's like, no, we're taking things seriously now, right? And so if we're going to do residential, you're going to be there for 1.5 to 2 years, voluntary, right? There's no forced treatment. And then we have outpatient treatment that is also based with evidence-based practices, right? The other thing, and this goes to Tess's point, 1998, solving the epidemic was the #1 issue for voters, right? #1 issue. Now it's 14. So when we, if we don't talk to our, and I've worked for Senator King, I've worked, in the legislature. If legislators don't hear from you, they're going to be thinking about something else, right? And so it's really important that we talk about the opioid crisis and about, the harm that it's doing to us and our communities with politicians, because that's when they actually start to do something, right? So in Portugal's case, again, remember this is a hierarchical society, unlike the Netherlands, which was kind of like a common bottom-up communitarian approach. Here it was a 9-person panel, started with the prime minister, and you kind of have a set of reforms, right? And what were those reforms? Very similar to the Netherlands. You had low threshold MAT, evidence-based therapeutic communities, as I mentioned. Again, look at this. Drug consumption rooms, 2019, right? 15 to 20 years after the initial reforms, right? Because it was done to try to help get people off the street, not as overdose prevention, right? Because overdose prevention, as we've mentioned, is more about toxicity and supply. One thing that Portugal did really well is reintegration into society. So non-absence-based employment, housing programs, tax deductions for businesses, and decriminalization. Catherine, I'm going to pick on you again. What did decriminalization do for Portugal? Does anybody have a guess of what the role of decrim was?
I mean, to us, to our families, it put people back to work and put families back together.
Mm-hmm.
So it made the community more impactful. What I would call the negative side of it is, to this day, when I see my family virtually at how you work.
Mm-hmm.
How you help with other and how you work.
Yep.
There's a whole idea in Portugal to put people back to work, put communities back together, put families back together, and it was just like taking meds for anything you had wrong with it, you took your meds and you went to work.
Yep. Thanks for that, Dave. Good point.
Did it lower the crime rate?
Yeah, I mean, if it's not a crime, the crime rate goes down, right? Any other ideas? Ooh, great point. Let's talk about that. All right, just hold that thought with me. Decrease stigma. Yep. Decrease stigma for who? Again. Mm-hmm. Mm-hmm.
Together, it can be isolated whereas you criminalize, then you take the stigma away from it, and you can begin to invest in the community.
Yep, for sure. All good points. Gentlemen here.
One of the things that I know it did is it took the cool away
Yep, right, exactly, right. When I visited, I'm going to talk about this, I think, in the next slide. I'll just jump there. But just before I do jump there, outcomes within a decade, heroin use dropped by 2/3. This is supposed to be 0.3%, not 3%. Overdoses cut by 1/5. New HIV cases plummeted, right? And the point here is that folks, like, we can do this, right? This is a solvable problem, right? We whatever it means to solve the opioid crisis, we can do it, right? And so for me, this is a very hopeful talk. We talk about hope. We just have to be thinking about the right ways and strategizing the right ways, right? So let's talk about decriminalization real quick. Because when we think about Portugal, decriminalization is what is usually talked about, right? But as we just saw on the last slide, decrim was one small part of a plethora of reforms, right? I want to say they had like 12 pillars or something like that, but they at least had 5 or 6, right? And so the point of decriminalization, right, is to ensure that people don't have criminal records that follow them and that impede them from integrating back into the community, right? That is probably the number one thing it does, because for folks who here work with people who have criminal records, it is incredibly difficult to reintegrate back into society, incredibly difficult to go back to school, incredibly difficult to get a job. I mean, I was talking with Catherine, and I remember from my own time working in the state, we had this person who, got clean and, went to school, got her MBA. After her MBA, she applied to all these places. She got interviews everywhere. She had 3 job offers. She accepted the first one. She went there. On the first day, they're like, "Oh, do you have a criminal background?" She's like, "Yes." Fired. They won. Went to the second place. Same thing happened. Went to the third place. Same thing happened. Right? And so we can talk about treatment. We can talk about housing, we can talk about, all of that stuff is important, but we have to remember the integration or reintegration aspect, right? And the decriminalization in the Portuguese case was really important to that, right? Making sure that people didn't have this thing that weighed them down for the rest of their life, right? In the Netherlands version of this, they didn't do decrim, right? It's still criminal there. But what happens is that if James is trying to employ me, right, and I have a drug possession charge, James can't go to the police and say, or to the state and say, what's Rowland's rap sheet? And then he sees all the stuff that I've done, and he's like, I don't like this guy, right? So in the Netherlands, what happens is that James asked the state, he's like, does Rowland have, what do you think of Rowland? State of the Netherlands. And state of the Netherlands might know that I have a drug possession charge, but that is not enough for them to prevent me from, sorry, been talking a lot. Trying to put a lot, thank you. But so the point is that they'll tell James, no, Rowland's good to go, right? Now, if you were a child care provider, and I had and my crime was, something to do with children or sexual abuse, something like that, then they'd be like, no, Rowland should not work with James, right? But it's a more nuanced project, and at no point can James see what my rap sheet is, right? And the idea is that, what happened, what I might have done in the past shouldn't, be a weight on me and lock me down for the rest of my life. So that's what decriminalization does. And to the point on teenagers, when I visited the drug consumption room, right, drug commissions, right, which is when somebody gets arrested with drugs in the Netherlands, if that person's the amount of drugs that they have on them, if that is under a certain limit, they go to these drug commissions rooms. They have 72 hours to show up. And the drug commissions is basically just a psychologist, right? And so as soon as they enter into that space, They do not have to go to the judge and to the criminal justice system. What happens if I'm caught with drugs while stealing? Do I still get charged for stealing? Yes. All right. We can still stigmatize behavior. We can still criminalize bad behavior, right? So, moreover, if I'm caught with drugs, even if it's under that limit, those drugs are taken from me, right? Because if they've caught me using drugs, it's because maybe I'm in a public space or something like that, and that is not acceptable, right? So just want to contextualize the decriminalization. But when I went to the Drug Commission, the person who was there with me was a teenager and had 2 parents, right? And the teenager was acting all teenager-like. And the parents were really, the parents were really worried, right? And so, 90% chance that teenager had been caught with cannabis, right? It might have been another drug, but probably cannabis. Whatever he was using, the fact that he entered that door, he was outside of the criminal justice system, he was within a public health environment, and, he went to go see a psychologist, and that psychologist rated him from high, low, medium, or high risk, right, for dependency. And then, assuming this gentleman was, low or medium risk, then he would just get proper information on cannabis use, the risks of cannabis, and perhaps a referral to outpatient treatment if he needed therapy and it was considered that was that. Ma'am who asked me about teenage use. If you're a teenager and you just got caught using cannabis and you just had that experience of going and seeing a psychologist, getting more information, do you think you are better off or worse off than having spent a night in county jail? Better off, right? Oh, there you go. So, right? So, anyways, and the point here is context. Before I jump to Brazil, do we have any questions on Portugal that I can help answer? No, we're tired of hearing me speak. I agree. Oh, yeah, passport renewal vibes. You kind of go there, have you ever renewed your passport? You go to the DMV, and you're just kind of sitting in like a government, line, customer service. My joke was that like, you go there, and it's just kind of like a government service. It's kind of like you're renewing your license or something like that, right? So it's kind of chill, right? Kind of bland. Brazil is very quick, don't worry, we're gonna get into question and answer. This is me on my second day in Brazil, in Cracolândia, which is the largest open air drug market in the world. And this was me behind the SWAT team as we entered a favela because they wanted to show me that the Comando Vermelho, which is the organized crime group in Fortaleza, was kicking out residents as part of their turf war, right? So why do I show these images? Brazil is, the Netherlands and Portugal are considered 2 of the safest countries in the world, right? And yet they have all these drugs and they have all this, public health and all this stuff, right? That's where, if you remember the beginning when I talked, public health is public safety, right? That when we do all of those things that we've been talking about for the past however long, right? You actually get greater public safety, right? And for me, Brazil was the opposite case, right? Because, so Brazil, for those who don't know, over 200 million people, never had an opioid epidemic. It's more of a crack and alcohol use problem. People killed by police, 6,000. United States, it's 1,000. So they have 2/3 of the population, but they have 6 times the amount of people killed by police. Homicide rate, just general, 20 per 100,000. US is 5 per 100,000, right? By the way, they have a universal healthcare system, which is considered one of the best in the world, right? And why do I mention that? Because I think some people think that, oh, if we just had universal health care, everything would be solved. Right? People live behind guards, behind fences, behind barbed wire. Public spaces are completely empty. Streets are empty, right? And so there's this retreat from public space. And so, I mean, they have a very strong culture of private spaces and so forth. But that also leads to a society which is the most unequal, or one of the most unequal in the world, along with Mexico and South Africa, right? So Brazil is not all beaches and samba, although that is a great part of it too, right? So in this chaos, in 2014, in the middle of Cracolândia, which is the largest open drug market in the world, Mayor Fernando Haddad, creates this program called Braços Abertos, where 500 people have access to housing, social services, and they can continue using drugs while they're accessing all these services that we've been talking about, right? Health treatment, something like that. 88 reduced their crack use. 52% reconnected with their family. 73% started working in some form or another, right? So 85 were in health treatment. 84 had not had identity documents before the program, right? And then this is where we're going to talk about political messaging a little bit, right? But we're kind of doing that with the public health as public safety, right? Which is the street flow in Cracolândia fell by 80%. I don't know how they, I don't know if that 80% is true, but like the point is that, the streets kind of got safer with local crime down alongside it, and 69% of Sao Paulo residents approved of the program, right? I think this is a really important because it talks about how these non-medical interventions have medical and healthcare outcomes, right? And also that, even though we are not utilizing it, opioid use disorder has a very easy treatment, so to speak, which is OAT, which is methadone, which is buprenorphine. That does not really exist for crack cocaine, right? Or necessarily alcohol, right? But if we use these non-medical interventions, we can have those reductions in use and those improvements in people's lives and in the community environment, right? So I worked in politics, so I have to have a political strategy, I guess. But tax dollars finally ensure reduction in drug use, end to public use, drastic reduction in overdoses and contracted diseases, streets and parks that feel safe, and emergency services that can better help your uncle with a heart attack, right? We need to build viable political coalitions and not shy away from the public safety debate using proven public health policies, right? So this just goes back to my vision. This is still a workshop. This is like, we're workshopping this, right? But, every state loves their strategy, so I kind of came up with my own. So look for the treatment bucket, low threshold, brick and mortar, mobile units, outpatients, and then long-term residential care, 18 to 24 months, right? Harm reduction, detoxify the supply. If we want to reduce overdose deaths, we need to detoxify the supply. Because even if you get a drug consumption room, even if you get an overdose prevention site, those are very hard to implement. Even in the Netherlands, even in Portugal, right? You're fighting the community. You have to give them a lot of goodies. They're usually still not happy about it, right? And again, it's more about reducing public use than it is about reducing overdoses. Naloxone, obviously, syringe services to reduce comorbidities, and drug checking, right? So that people know what they're using. And the drug checking is for people who might be on the street, but also for the recreational user. Plenty of us in this room who enjoy drugs once in a while to have a good time. We should also know what drugs we are using. Public safety. James, what did I put under public safety? What did I put in?
Housing first.
Housing first, right? What else is under public safety? What's the setting?
Integrated day use sites.
integrated day use sites, right? Which is another term for drug consumption rooms, right? And there is a stick, right? If folks, and the stick is more trying to get folks to go to those places rather than bring them to jail, right? But what am I trying to do here, right, is when we call them public safety officers, we call them law enforcement officers, public safety officers. All right, law enforcement is absolutely part of public safety. But housing first, integrated day use sites, those are the key, those are the foundations to public safety. All right, and I think that is kind of like the mind shift which I'm trying to advocate for. The last two here are reintegration or integration. And why is reintegration in parentheses? I haven't picked on you yet.
Because it's assuming that the person hasn't been integrated into the community.
Exactly. Right, who started drug use at 13 years old. Right. He's not reintegrating, he's integrating. Right? He has to learn how to be in a bookshop with somebody else. He has to do, like, how do you have an interaction at a store, at a restaurant, like those types of things. Right? So that's why reintegration, integration. Right? So this is where the criminal justice reform comes in, whether you do it Portuguese decriminalization style, whether you do it the Dutch VOG style, which we talked about, figure out what works best here in Maine, here in the United States, given our laws, right? Recover communities and support, still huge, right? Employer and school engagement, stigma reduction, tax breaks, etc. Right? When we talk about stigma, I think it's very hard and honestly, in my opinion, probably impossible to really change the entire culture of the United States, the entire culture of Maine, to accept people using hard drugs. But if we have targeted anti-stigma campaigns that are part of an overall strategy to engage and get people back into our communities and reintegrated and up on their feet, then I think it can be really, really helpful, right? And then third spaces, to our loneliness expert over there, right? Art, music, yoga, softball, dance, Shakespeare in the Park, all you want. But we need to, get people engaged in their communities. Prevention and resilience, I'm not a prevention expert, so I'm sure whoever is will tear me apart. But from my perspective, the main things are kind of skills trainings, teach resilience and communication, because I think ACEs will always be part of our society, right? And what folks with strong ACE scores, adverse childhood experiences, decide to use for their drugs to soothe will change. And also making sure that folks are having after-school programming. So the umbrella of the 5 is community stakeholders, treating stigma reduction, peer support throughout, accountability and structure. Thank you. So can somebody do a time check for me? I don't know how much time we have.
So 5 to 11.
5 to 11, so we have 20 minutes. So how much time do we have? Somebody look at the calendar. That's good. About 15. All right. Does anybody have any questions? Yes.
So with your with the housing and not requiring sobriety, is there a work requirement at all?
Doesn't have to be. Doesn't have to be.
I think it's important to have something to occupy your time and some place to go.
Absolutely, right? And that's where like the integrated day use spend, right? Because people also don't want to spend their entire day at the house, right? I think I was talking with Preble Street, and they're saying 30% of the people, he gave kind of like a general number, he was like 30% of the people who are using in Deering Oaks Park, they have housing, right?
Is the state going to allocate money to buy houses, like grants and whatnot, for this,
Yeah, that's a good question. Does it make sense for the state to do that, or does it make sense for the state to, kind of use CHOM or Preble Street and stuff like that to just make sure that people have supported housing, right? Because the key with housing first is not just, hey, we're going to pick you up and we're going to put you in a house, right? Because that's a very hard transition for folks, right? You have to have those wraparound services, right? So it usually has to come with a service provider who can kind of provide those services, right? But but what do you do, right? You do have access to referrals, right? And you do have workshops for people who want to join the workforce. Hey, you really like working with your hands? We have a lack of carpenters in this state, right? Or hey, you want to, you're really into healthcare? Like we have a lack of nurses, right? So how can we work with existing training programs to kind of fill some of the needs in the state in terms of the workforce, and not just assume that because a person has used drugs or has addiction that they only want to work in like construction or peer support or something like that, right? That they deserve to just have dreams to do whatever they want. But the key there though, right, is also that not the decrim, but like the justice reform part, criminal justice reform part, right? So that they can actually access those jobs. Michelle. You have a question?
I'm Elizabeth.
Oh no, you look like you're, do you know what I'm so sorry. You look, anyways, yeah. Do you have a question?
I do.
Mm-hmm.
And I don't know anything about this, but maybe you do. I was told from a very respected psychiatrist that they tried to model Portugal's decrim in
Oregon.
Yes, and it failed miserably.
Mm-hmm.
Maybe 2020. I don't remember exactly when it was, so I don't know the answers. But do you know anything about that?
So I do know a little bit about that. I'm not an expert on it. From my understanding, right, is they kind of, the Portugal decriminalization process, as we talked about, the decrim was one part of a set of reforms. Right, it was a set of reforms, and so without those, I have a slide in my other deck, which is one of the top doctors from Portugal that says decriminalization alone does not help and can actually make things worse, right? And so you have to have the supportive housing, you have to have the drug, you have to have the access to care, which they did not have, right? Because if you remember, when they did their decriminalization push, that was also like right when COVID hit, right? And so, the resources, the public health resources that were kind of supposed to kind of do a Portuguese-esque model, were all diverted to COVID care, right? And dealing with the COVID crisis, right? And so at the same time, folks in Oregon, from what I understand, when police intercepted somebody who was using drugs, they didn't take those drugs away, right? And they just kind of gave them a slip being like, oh, here's a number you can call, right? In Portugal, drugs were taken away because, again, they're not promoted, it's a conservative society, they don't believe people should be using drugs, so the law enforcement takes it away, and you have to show up to a drug commission within 72 hours. And if you don't show up, a police officer is going to come to your door, right, and make sure you show up. Or ask you to show up, because if you don't show up, then the criminal charges are put against you, right? So you have the opportunity, this is all voluntary, you have the opportunity to go through the public health pathway, but if you don't, there's still consequences, right? So I think that, unfortunately the Oregon was tied to Portugal, and they said that they did what Portugal was doing, but unfortunately it's actually quite divergent from what Portugal did, and that's why I'm hoping to have this talk and kind of share people, yeah. Other questions from this side of the room? Yeah, in the back.
I'm just wondering, we were talking about the government
Yes.
program. So it sounds like getting people into housing and also connecting them with work as well. Are there like specific work programs, or like how does that whole thing work? I'm just wondering if it's like an actual, is there caseworker or somebody that's helping connect them to specific jobs, or?
Yeah, so absolutely. So it's like, so you're at a you're a direct assumption room, integrated day center, however you want to call it, and and then you say, you're talking with your caseworker, and you say, hey, I would love to make my own money, so it's like, okay, well, let's refer you to this program, right? Just as if, they were like, oh, I want to, get into treatment, I want to do that. Okay, I'm referring you to this person, right? And so they have specialized services which help train folks or get folks into the trainings that they need or that they want, right? And that's accessible, right? So, but I think that's a really key part. And part of it is the skills, like the actual skills, like, oh, I want to become a carpenter. How do I become a carpenter? Part of it is also, going back to the integration, reintegration, just social skills, right? Like, how do you talk to a customer? How do you talk to someone like that? So which is key. Yeah.
They also have workforce development that paid part or all of their salary for a year?
Yeah, great point. In Portugal, what they did, and that's absolutely right, it was Sean is absolutely right, which is, the state, if you were a small business and you employed someone who was, still using drugs or in early recovery, however you want to define that, you got tax breaks, or the state would pay that person's entire salary. So you basically got free labor, right? And so that's also how you get, folks on board, right? The employers on board, stuff like that. And so that kind of ended in 2007, 2008, because of the financial crisis, and that has kind of cut into the public health budgets of Portugal. But they did that, absolutely. Gentleman here.
Thank you. So I'm a lawyer and I'm interested in particular your public safety piece. And there's been a lot of conversations about safe injection sites. You call them sort of public places. Can you comment on whether federal law allows Maine or Portland or any other place to do that?
I do not think I'm not a lawyer, but I will say that I was just talking with I was just talking with the folks in Rhode Island who have this site. And by the way, I was just talking to them, I haven't visited it, but they have a great site from what I could understand, right? And they're able to operate it, and they're using opioid settlement funds, not kind of state taxpayer dollars to fund it, right? But they have this model which, worked really well in the Netherlands, which is this integrated site, right? Which is where you have a place where people can use the drugs, but then a place where they can hang out, a place where there's caseworkers, right? A place where they can eat food, right? So it's kind of like this integrated thing, which is not all sites, right? The site in Paris, the safe consumption site in Paris, is literally just a room. You go in, it's very clinical. You go out and you're back on the street, right? And it's right next to Gare du Nord, North Station in Paris. And it causes problems for that community. So that community is not happy with it, right? But what the Dutch model is like, you actually want, not that you want us in your community, but we're gonna be here in this community. It's gonna be safer. We're gonna have an extra police officer. We're going to implement, we're gonna put new lights so that there's no dark alleys or anything like that. Right? And what the Providence did is that they really engaged the community from the get-go to make sure, what do you want? What would safety look like for you? And make sure that those folks were engaged. And I think that's why this program has been so successful. In the back.
Portuguese austerity, but it feels like one of the big behemoths in the room here is that our medical model is so complex compared to many of the universal healthcare systems. And so a lot of what we end up struggling with on the day-to-day is the Tetris game of, oh, this person has this type of insurance and that treatment bed is only taking that. So can you speak a little bit, I'm making assumptions, but Brazil and Portugal may have struggled with some of the resourcing on the treatment side, and like how did they navigate making sure it was possible to get somebody into treatment if they wanted, or into detox if they wanted in that window?
Easy question. So Portugal, I'll start with Brazil and just saying that Brazil, yes, does have a universal healthcare system, but universal healthcare, when we think about, oh my goodness, social determinants of health, right? And we talk about universal healthcare, at some point universal healthcare can't fill the gap that social determinants of health like lays on the population, right? Average wage is around $300 a month, right? You have over something like 22% of the population lives under the UN poverty line, right? At the same time, it's one of the most unequal countries in the world, so you have people, driving Ferraris and kind of doing all that fun stuff, right? And so universal healthcare and it's a massive country like the United States, it's the same size as continental United States. And so, universal healthcare can be helpful in some circumstances, but it's definitely not the end all be all, and that's why I focus so much on the non-medical interventions. When it comes to, and also I wrote a whole piece on this, but in Brazil, because you have gang warfare in certain cities, if this is a road, and I live on this side of the road, and the medical center is on that side of the road, right? But that's one gang and this is another gang, I can't cross that road. I can't access services, right? So think of all the problems that we have and think of then trying to add that onto it, right? For Portugal, which is also universal healthcare, because it was universal healthcare, they were able to really kind of push just kind of do public investment into it. But there's a lot of private healthcare as well. Portugal has a mixed model, right, where there are private insurance companies, right? And so the key for them is that, we're going to help subsidize, insurance for these folks and for these types of programs, but it has to be evidence-based, right? No horse petting for a month. We're going to do outpatient evidence-based treatment, or we're going to do 1.5 to 2 years residential care, right? And so that's their model. The Netherlands does not have universal healthcare, right? They have a fully private healthcare system, right? And so I think that would be worth looking a little bit more into how they did it, right? Because it's most similar to us. But when it comes to these low barrier stuff in particular, I think that's something that the state can invest in and kind of cover, to be honest with you, right? I think the mobile program in Lisbon, which covers a population of 1.2 million people, or I think it's close to 2 million people, and it has I have this data on the other slides, but it's close to 2,000 people, only cost them about $1 million a month, right? When I was in state government, I had we were giving out 500,000 to people without, just what are you guys doing? No, but what I mean is that there is money in the state budget. We just have to be allocating it for things that work with a strategy. But I think it's also a conversation that we have to have with insurers, right, and making sure that they're insuring those types of care. Yeah.
Transportation is a problem in Maine for people to get anywhere. And so I know they probably have more public transportation in Netherlands and some of the places, but how do people get to these centers if they don't, and you don't want to give them cars if they're fine?
No, great point, right? And that's where the Netherlands is kind of unique because it's so small. And also Portugal is a little bit different, it's a little bit more spread out. Obviously Brazil is super spread out. I think you have to do, at least when I was working with veterans, you kind of have folks who will drive around and bring folks to their medical appointments at the VA and that type of thing. And so I can imagine a system where you kind of have a volunteer base, or you have folks who are paid to kind of do that work. But I know here in Maine, it's a big issue, right? But that's also why we need to be thinking about how can we have smaller sites rather than, we're just going to do this one big project, right, that's going to have everything. It's how can we spread out these sites to make sure that they're most accessible to everybody, right? And at the end of the day, right, I believe in people's ability to integrate, reintegrate, recover, however you want to call it, when they're given the resources, right? Or at least when the barriers are less high, right? And that's where the criminal justice part comes in, and that's where the safer drug supply comes in, right? Because if people are not dying and they can actually access work, then I think they're willing and want to do that, right? The problem is that we've put up so many barriers to them. So one last question, so that I think we're heading on to the next thing.
So when you mention safer drug supplies and things of that nature, and there being rules specifically, for this use, are the dealers there? Like, so you're able to monitor the drug supply? I mean, like, that use is happening and those things are happening, but like, is it known where the people are getting the drugs from, or are they getting it right there? Like that's my kind of question.
Yeah, so different model, different places, like in Switzerland, for example, they kind of control who the dealer is. They kind of know who the dealer is, and they kind of let kind of an authorized dealer into their site or into their site to make sure that that person is only selling like the good stuff, so to speak, right? But when I talk about the supply, I talk more about like how do we get heroin-assisted treatment, or how do we do like the morphine sulfate like they do in France, where what people are selling is the quote-unquote good stuff, is the pharmaceutical stuff, right? And I think that's what we're talking about. Because even if you have this authorized dealer, so to speak, but he's selling fentanyl or he's selling xylazine, then that's not helping anybody, right? So, anyways, thank you all for your time.
Thank you.
Hey, thank you. Thanks for coming. Have a good day.
Yes, you did a very good job. I'm also with Pearl Street.
Oh, hi, nice to meet you. Thank you so much. Glad you guys enjoyed it. Yeah. I'm glad you enjoyed it. Yeah, go ahead. Well, feel free to reach out anytime. And I think this will be online too. Yeah. Please, anytime. Thank you, David. I got it. Yeah.
Especially as it relates to this.
Yeah.
I get all the safety issues of having safe injection sites.
Yeah.
But in a sense, if we're actually discrimination and stigma, it's about the side of and that's about environment.
Yeah.
And people who are with realistic perspectives don't get confronted by challenges. So I'm kind of like, I've been in the field for 4 years, so a long time. I support injection sites. How do we still address the stigma and disease changes? So that it's more rhetorical than anything else.
Well, I think like where I would push back, right, depending on what your point is like, do we have to? I guess I'll ask you a question, which is like, when you're talking about stigma and changing stigma, what are you trying to change exactly?
Yeah. We made great innovations, however.
Yeah.
Safe injections, which just allow people to keep in their addiction. And we have to do that. So
what I would say, right, is that if we have these integrated centers, we have this comprehensive thing, right, people actually do use less. Right.
Yes.
Right. And so what I think
use less when we say innovators, we've got better job for housing folks.
Right.
Services.
Right. And so I don't think at least what I saw in Portugal and the Netherlands is that they didn't get to a point where they're like, oh, like using heroin is okay, like using drugs is okay, like. And we're talking about like the most progressive countries in the world, and we're not even talking about China, Asian countries, which are completely right. So I think like where we win like the political debate, right, is saying I actually agree with you. People using heroin is not great. It's not great for them. It's not great for their families. These programs actually help these folks use less, and within 5 years, kind of get back reintegrated into society.
People are really quick fix society. So, but people not wanting to invest in that sort of time.
I mean, if you do it comprehensively, like the Portuguese, like when they did their set of reform, like within 2 to 3 years, things were good enough that when the political change came, right, when the left was flipped out and the right came, they actually kept it, right? But you have to, when this is from the time of campaigns, right, where I just think of like, what do people
If people see that folks are not on the street, they think the problem is being solved. And my perspective, and you may disagree with this, but I think people care less about how it's done and more about, like, the fact that they can walk into their notes, right? And we've done 25 years of this, and people know that it's not working, but they don't have, in my opinion, don't have a framework of like how to do it.
I agree.
Right.
I totally agree. And that shifting of the paradigm is so kind of key.
Yeah.
We can help them shift from it's an expense to what's the return on investment.
You don't want your taxpayer dollars to go.
So,
but it's showing right now. Right now, when somebody overdoses, that police call, that's you. That fire, that's you. By the way, when that person who goes to the emergency room, you're paying that in the premium, right? So you're already paying for it. I don't even pay less.
I get this.
I won't even pay less.
I get that.
You know?
So,
but right, but like, that's a rhetorical argument, right? And then I think, and that's why I think we need to be more. That's why I'm not afraid of that, like public safety debate. So that why we like jump into it and like, oh, like, my tax liability. It's like there are big issues, actually, right? You're not thinking about it all day. Right?
and the other part of that shift for me is we always have been talking about the expenses of addiction. We haven't talked about what's the return on investment for recovery. What are people going to get back positively, pro-social, but also economically.
Right. Well, in the last point, but like the Z digestion in Amsterdam, if you ever go right off of Amsterdam Central Station, right now it's full of.
I was in the
Oh really?
The good side.
Yeah. But so it's it used to be 20 years ago. It used to be people no businesses, nothing like that. Now it's the most profitable part. Neighborhood in all of Amsterdam, both for business and also for the city, because they're getting tax revenues from people being there and spending their money and doing all that stuff, right? And so I think that we learn to really cycle, and we just have to be more better at explaining it, and that's what I'm trying to talk about. So I appreciate your time.
Yeah.